Please welcome to the stage Sarah Henn, Chief Medical Officer at Whitman-Walker Health, and Lefert, Senior Director of Policy and Legislative Affairs at NASTAD, and Mardrequs Harris, Senior Manager of Capacity Building Assistance at the Southern AIDS Coalition. Here to lead the conversation is journalist Susan Salney.
Thank you, and good morning again. I thought we'd start by diving into what is the great paradox of this crisis in the U.S., and it's that so much progress has been made, but not for everyone and not everywhere. Now, Anne, your work gives you a view of all 50 states, so I was wondering if we could start with you. If you could tell us a little bit about that work and what disparities you're seeing across the country.
Yeah, so as I think the last panel talked about a little bit as well, unfortunately, HIV is not different than other health conditions and access to health care in this nation. And so we see disparities in all sorts of things. We just see disparities in the populations that are affected. Not everybody is affected equally. There are far more infections among Black and Latino young gay men than there are in other populations. We also see disparities in health outcomes. So access to care, time spent traveling to care, viral suppression, ability to see a doctor who knows about HIV, the ability to access PrEP services. And so we are seeing these disparities in pretty much every step of the way, and that impacts not only individuals, but it also impacts the communities and the populations in which individuals live, and then increases or decreases risk of populations, which then is a circle that just continues on.
And there are whole regions of the country that are falling behind. Yes. Who's struggling the most?
You know, I think we hear a lot about the South. We have a lot of new infections in the South. Now, that doesn't mean that there aren't new infections in other places of the country as well, but I think what is slightly different about the South is that we have seen them have less robust public health infrastructures. And so, you know, many of the southern states were later to expanding Medicaid. Some still are working to get there, and we are very hopeful that they will all get there. But these were some of the states that had you know, very slimmed down Medicaid programs as is, and did not have as much access to care, did not have the same public health infrastructure, did not have the same educational structures to teach children about HIV and to assess risk. And so I think where our attention in the advocacy and in the U.S. side of things is really on trying to stem that great number of new infections in the South.
Mardrequs, you're based in Alabama with the Southern AIDS Coalition. So from your vantage point there, what's going wrong in the South?
So before I start with what's going wrong, I want to acknowledge the resiliency of people who live in the southern United States, because they have a lot of issues and barriers that they have to overcome that some of the more progressive areas of our country don't have to deal with. Some of the challenges that you can immediately call out are those isms that still exist, which would be racism, and some of those phobias, transphobia. And another issue is faith communities. A lot of southern communities, particularly in communities of color and more Black specifically, faith is the basis of what the community is built upon. And when faith institutions and agencies refuse to talk about HIV, refuse to talk about LGBTQ people, then they become liable for some of the decisions that cause trauma, because they're taught to hate themselves, because there's judgment associated with loving someone outside of the heterosexual or heteronormative relationship. And then parents build homes based off what the pastor said, and you know, and that is how
a cycle begins.
So there's really like the ecological model that we have to pay attention to, where the client is here, but then there's family, then there's the community, then there's school, and then there's the politics around the area, then there's patient care, client care, going to the doctor's office, the stigma associated with going to facilities who are deemed the HIV places or the AIDS places. And so there are many, many things that play a role into why I think the South is falling behind, and that is also inclusive to access. And the South contains many rural areas where there's no way to get to a doctor without taking multiple buses, or without having to wonder if you're going to get there. Are they going to incentivize you? Then there's the income, there's poverty. So there are a plethora of reasons, but I do also like to couple that with there is a resiliency that exists in the southern United States that is remarkable.
And Sarah, at Whitman-Walker Health here, I'm guessing you're seeing some of those same issues in the district.
Absolutely. You know, DC has made enormous progress in the last 10 years. I've been in Washington, DC at Whitman-Walker for almost 12 years now. And, you know, the number of new diagnoses in the district have dropped in half, but we are seeing some stagnation in that. And we're definitely struggling with the same challenges. The communities of color are disproportionately affected. Last year in the district, 1 in every 3 new diagnoses was a man who had sex with men. 1 in every 3 new diagnoses was a person of color. 1 in every 5 new diagnoses was a Black woman. So I think I think you can't talk about HIV without talking about social determinants of health. Excuse me, and the effects they have on communities.
How are key populations at risk falling through the cracks when we are aware of who they are? Is it a messaging issue, an infrastructure issue?
I think it's multifactorial, right? I think we absolutely need to do a better job in messaging and reaching the right people and working with peers and working with faith leaders to talk to communities so that people are having these discussions. But I think you also have to recognize that stigma really, truly still exists, and that's something that still people are battling, and that if you are poor and you are worrying about housing and food and paying your bills, perhaps taking care of your HIV or getting tested, it drops on the priority list. And so unless we address some of those barriers to accessing healthcare, we aren't going to be able to achieve our goals.
A huge part of the conversation among activists, I hear, is about combating stigma. What do you think are the best strategies for combating stigma?
I personally think stigma varies from community to community, so there will be no massive plan that we can put together that addresses stigma everywhere. But I think normalizing the conversation around HIV/AIDS, who it impacts, what it looks like, some of those social determinants of health would help in kind of moving the needle on stigma and making things less stigmatizing, because we also talk about stigma from facilities and entities that we go to, but then there becomes an internalized stigma. And how do you address internalized stigma that comes from institutions or systemic issues or concerns that people face based on communities where they are? So I don't think there's a plan that can address it all, but it's normalized. And then HIV neutralization, which is around not making a positive result more important than a negative result. So when we have all of these resources for people who get a positive result, but then when someone gets a negative result, we say, keep doing what you're doing. Oh, have you thought about PrEP? Oh, have you? And then we send them away. But they too have issues that if we don't address those issues, they will then fall in line with being some of those new diagnoses. They have housing issues. And you have to humanize each individual that comes into your space. You have to deal with them as a human first, and then deal with the issues that follow them being a human first.
Now, you mentioned PrEP, so let's talk about PrEP for a moment. As effective as it is, still seems not to have caught on with all of the at-risk community. And why do you think that is? What's going on? Sarah?
So PrEP is pre-exposure prophylaxis. It's a pill you take once daily to prevent HIV infection. And I think we've seen a lot of people coming through our doors who have a higher health literacy, who kind of acknowledge that they may be of increased risk for HIV, and they come requesting it. And we have yet to make the transition as a medical community to going and helping to identify folks who are at the most risk, really, and those are young MSM of color for the most part, and really talking, and young women of color, and talking to them and helping them work through what it would be like for them to take a pill every day to prevent HIV, and also helping them to acknowledge the risk that they're at just by the community they live in. And so I think, you know, people don't want to think of themselves as being irresponsible in love. But, you know, if you live in a community where there's a high prevalence of HIV, the fact that you are in that community makes you high risk. And I think we have to acknowledge that and talk less about individual behaviors and more about kind of why sometimes who you are makes you at increased risk.
And the other thing I'll say, is this still on? About PrEP is just last week, the U.S. Preventative Services Task Force gave it an A rating, which then means that insurers will need to cover it as a preventive service free of charge. And so that takes one of the barriers, hopefully will really eliminate one of the barriers, which is access. Now, that is for people who are engaged in care, but that will help there. I think what it has the possibility of doing is exacerbating the disparities amongst who is on PrEP. And so what we will have to do is maybe we can turn our attention away from fighting with insurance companies and Medicaids to make sure that they're making it accessible within their plans, to really doing the education for providers and people who may want to investigate this for themselves. And so hopefully with this new really groundbreaking for HIV decision, we can take it even further.
We're also at a moment in this country where there is an opioid epidemic. I wanted to ask you about the intersection of that with HIV/AIDS. What's the impact been?
Yeah, you know, injection drug use, in fact, new infections from injection drug use was an area where most jurisdictions had seen tremendous success. We have the science. We know that syringe service programs are incredibly effective. And now what we're seeing with the opioid epidemic and just the injection of drugs, whether they're opioids or meth or other drugs, is that we are ticking back up. And so places that had really seen very few new infections related to injection drug use are now seeing more and more. We know that everybody talks about the Scott County, Indiana outbreak, which was very significant. The other thing I will say about this is that it really started with new hepatitis C infections. So a significant amount of people living with HIV are also co-infected with hepatitis, and it makes it that much harder to take care of all of the needs. And we now have a cure for hepatitis, but we are really focusing on trying to ensure that the opioid response in this nation includes comprehensive harm reduction and funding for syringe service programs. And this is an area where I think we need leadership from communities, cities, mayors, governors to say, we know that this is incredibly effective. And we have seen changes on this. You know, Vice President Pence, and when he was governor of Indiana, came to support syringe service programs. Senator McConnell, because of the burden of disease in his state, has supported funding for harm reduction programs. So I think we're getting there, but it is an area where we are going to need to invest more because of the sheer number of people who are now injecting drugs.
Right. Mardrequs, I wanted to ask you why this work is important to you. You've dedicated your life to it. Can you tell us a little bit about your personal story?
Sure. So this work is important to me for varying reasons. The main reason is because I am a part of many of the communities that are still in 2018 most disproportionately impacted by HIV. That is Black folk, that is the Black man, that is same gender loving people, that is the faith community, and I have friends who had no one to talk to, who could not talk to anyone because of fear of displacement from their homes, being kicked out of their churches and not able to serve in churches anymore. And I actually fell into HIV work through Emory University's clinical research. They were doing HIV vaccine trial 505. And I moved to Atlanta, and one of my friends was like, you would be great for this project. And I got there, and I began to learn about the many disparities, and that how a lot of the boxes that needed to be checked, I was a part of a lot of them. And I was like, wow, but I did not see me or people that looked like me at a lot of those tables.
Okay.
And I realized that I have to take advocacy and advocate for myself versus always depending on other people to advocate. And people are more prone to, it's not always right and it's not always the case, but people are more prone to be responsive to something if they see someone relatable, or if they see someone that looks like them, or if they see someone that speaks like them or understands where they come from. And from there, I began to get on little boards, little committees, go to events and learn. And I really was intrigued by the science of it all, which it blows my mind now, so I'm not into the science part. I learn what I need to know to be able to be effective, but then I lose it because I'm like, oh no, science is not my thing. But just knowing that a lot of the boxes that we're checking off now, my face is there, and that very well could always be me in any of those things.
So powerful. We're going to take it to the audience in a moment, but I just wanted to ask you quickly, is there reason to be optimistic about the most at-risk populations at this point, the people who are suffering most? Do you feel any optimism over where the fight is going?
I think you have to be optimistic. I think, I think we're in a period where we need to re-up our game. Like in the late 80s and 90s, there was such a coming together of community and activism and research, and we've made enormous progress. And, with effective therapy, and now we have tons of single tablet regimens that I think, it's natural that you kind of, through that course of treatment, you're like, okay, we've got this now. We have tons of single tablet regimens. Oh, maybe we're done. And I think we know we are not done, but it's time to take stake of where we're at, where we've come from, and face the new challenges. So, and I think it's a little bit different than what we've previously done. It's a lot more about prevention. It's a lot more about reaching the most vulnerable communities and getting outside of our, medical centers or our clinics, and working with people who are most effective in figuring out what they need and how to get them access to the care they need.
It's a new phase with new challenges. Okay. Yes.
Hi, my name's Amber Lindy. I'm with the National Institute of Health and Department of AIDS Research. And my question is really for you, for the adolescents, the young MSM of color. We are having so many issues getting our researchers to get this population, because by the time we get them, they're over 18 and they've had HIV for a few years and they're already very sick. So how is the, as far as the southern cohort or the rural population, how are you reaching out to that population so we can get the research to get to those people so we can get them treatment?
One strategy that we're doing is actually going into communities and doing workshops and trainings to try to normalize the conversation around what HIV looks like, who it's affecting, who it's impacting the most, but also trying to get buy-in of parents, trying to get buy-in of community leaders, trying to get buy-in of those what we call social networks, social and sexual networks, and that is there is some person, a part of every social network, that you can make a connection with. And once you make that connection with that individual, then you have access to the rest of the network, because every group has a leader per se. So it's about strategizing how to infiltrate, and that's a horrible word because, but really getting into those circles and then making sure that people trust you. Because I don't want to talk to you as a 16-year-old about my sexual life, about my risk, which is a term I try not to use when dealing directly with people, because I think it's become stigmatizing to an extent. If I can't go home and talk to my parent, if my parent has shut me down, then I then become closed off. So it's about finding those means and making things relatable, making them fresh, making them new, allowing them to be a part of the building process. We tend to build things and then take them to people versus allowing people to help us build what we want them to buy into. If I build something, I'm more bought into it than somebody that brings me something already built and say, now what do you think about this? Does it matter what I think about it? Because it's already built.
Okay.
Hi, my name is Mark Schoen. I'm a filmmaker. You talked about prevention strategies, and the problems with it. If money and politics were not a problem, what would the ideal prevention strategies be?
I mean, PrEP is a big part of that strategy, and so what governments can do to make, especially when we're talking about adolescents, make adolescents be able to access care without parental consent, I think is really important. We're lucky in DC that sexual health care for adolescents doesn't require parental consent, so we can prescribe PrEP for adolescents without parental consent. But those kind of laws and policies throughout the nation would be very important to allow people to access care that they need and to make care available. I mean, we have to also talk about being able to afford this care. And if it's on your parents' insurance and you don't want your parents to know how that works, to allow for that confidentiality for youth to get the care they need.
Well, I think we'll leave it right there. Please join me in thanking the panel. Thank you very much.